This is a Byja Broadcast Enterprise show.
Once your asthma is out of control or there's enough damage to the lungs and the volume of the lungs and the function of the lungs, it's not reversible.
Shirts with pockets on it. Can we stop it?
I used this analogy earlier today with one of the patients. I said, I am literally in the game with you, but I'm calling the plays and hoping that you can execute the plays once you leave the office.
And look, if you got mucus, you got mucus. The color, you can't diagnose yourself by the color. You know, that's...
Say it again. Say it again.
You can't diagnose yourself by the color.
Dr. Zero. Say it for the
Dr.
people
Zero.
today.
Boy, I got promoted. Boy, look at me.
Here comes Byja Radio. Byja Radio. With Dr. Byron Jasper and PatientZero.
Welcome to the Byja Radio Show, recording live. The content in this show is intended for informational purposes only and does not constitute medical, diagnostic, or treatment recommendations. We do recommend that you seek the advice of your physician or other qualified healthcare provider with any questions regarding your health.
Coming back in live in full effect with Byja Radio Show. I'm your host, Dr. Byron Jasper, and we are kicking off Season 5, Episode 46. We had 45 last week, and happy to say that it was a really good episode. We got a good feedback with universal healthcare and kind of talking about that and giving some people some intros to what that can be. And ultimately, we are coming back for another amazing episode. And if I'm saying we, that must mean I'm talking about myself and my amazing co-host, the one who makes it so simple for people to understand, speaks in a language that is so fluent in greatness is what I call it. And more importantly, the gentleman that everyone comes to see, because we did settle this. He can try to argue it, but we literally went to social media and there was an overwhelming response that the majority of people come to the show for this man, and it is PatientZero. How you doing today, brother?
I'm doing fantastic. How are you?
I'm doing fine, man. My ego may be a little bit bruised, but ultimately, I'm doing fine. I'm not going, I didn't cry in the car or nothing. I didn't do anything like that.
I demand a recount, man. I think you put some people up to saying PatientZero is the reason why they listen.
Yeah, I mean, ultimately, if that were the case, I would say that. I might have, tempted some people to say one thing or another, but it definitely wasn't you. So all that being said, the people come for PatientZero, we got to give them PatientZero. And with that, I'm okay with that. I just have to play my role. And as we have already spoken, I just got to do better. So based on that, my friend, we're going to talk about something that a lot of people may be aware of and have experience with, but at the same time may not understand the gravity of these potential diseases we're going to talk about today. To recap, we've done episodes on things like high blood pressure, diabetes, high cholesterol, kidney disease, thyroid disease, mental health, and even things like respiratory diseases. So ultimately, we now have a potential category that I say, well, what haven't we talked about? And the one thing I don't think we spoke about is lung disease, because respiratory diseases we talked about were more bacterial versus viral. So now let's talk about more things that are disease states of an actual respiratory system. So we're talking about different things in that category, my friend. And these are some things that I'm sure you've heard of, but maybe not had a deep dive into. So we're going to potentially cover at least 4 diseases. Maybe 2 are going to be heavy and the other 2 may not, just depends on our timing. But we're starting out with a basic one. So PatientZero, what is the most basic respiratory disease you can probably come up with that pretty much everybody in the world has probably heard of? It may be called something different in different languages, but it's probably the same concept over and over. So which one do you think we're going to start with if you had to take a guess?
So being that I speak English, I feel like our president is going to try to rename English to American. Being that I speak English, I'm going to go with asthma. And asthma, I think everybody remembers the little kid in the class that had to go hit this pump every now and again when we were in elementary school. I don't know if you'd have to have one of those kids in the class back in the day.
Yep, I agree. So the simple low-hanging fruit of respiratory diseases is probably always going to start off with something like asthma or asthma itself. So PatientZero, I put some notes in front of you. Let's talk specifically, if you don't mind giving the people a definition and a breakdown of what asthma potentially is. And again, we're going to try to keep it simple. We won't go into too much technical jargon and things of that nature, but we definitely want to go ahead and at least give some definition. So what you got for the people in defining what asthma is and what's happening with asthma as it starts to go into effect, if you will?
So asthma basically is chronic airway inflammation and bronchoconstriction, right? Your airways become hyperreactive, so that's narrow in response to triggers. And your airflow limitation is reversible, key distinction from COPD, right? So key symptoms in patients should recognize is intermittent wheezing, especially at night or early in the morning, chest tightness or pressure sensation in the chest, shortness of breath with exercise, cold air exposure, or illness. Also, a chronic or reoccurring dry cough that gets worse at night is also a good key symptom.
All right. So hit some high points that I think we should go through just to kind of give people a little more insight. So first and foremost, you said asthma is chronic airway inflammation and bronchoconstriction. And the summary of that, and I think you hit the point that I think a lot of people may miss, is that it is where your airways become hyperreactive, right? So your airways are supposed to be reactive. You start running, you want them to do what they're supposed to do. They react to you running. They do things to help you get air into your lungs so you can keep oxygen in your blood. That's what the lungs are supposed to do, oxygenate the blood. But when they get hyperreactive, they go from being wide open, right? So think about really open tubes to now they constrict. So they look like this. And when those tubes constrict, we have a problem. And the problem that we tend to have is that you can't get enough air into the actual tubes. You can't get oxygen into the bloodstream. So you start to suffer and have symptoms. And what are the symptoms? You already said wheezing, chest tightness, and shortness of breath. Those are the ones that we tend to have. When it's really severe, some people go from having wheezing and shortness of breath and chest tightness to coughing. And they cough, cough, and cough. And the worst part of the cough is that they don't really have any resolution of the cough when they take things like cough medicine. And it's because, again, the cough is not from something that a cough medicine would treat. It's usually from reactivity that's hyperreactive. So in that case, we need to obviously try to calm the lungs down and the reactivity down and stop the lungs from being constricted to being more dilated. And that's where the medicines come in that help with causing the dilation to happen in the lungs to not over constrict or bronchoconstrict. So with that, PatientZero, what are some of the things you'll hear people say potentially when they say, well, I'm having these symptoms, but, I can't have asthma, right? My favorite in the clinic, as you can imagine, is, oh, well, I grew out of it. That's my favorite. That's
Right.
my favorite, right? I was a kid and I had it and I grew out of it. Now, the grew out of it is not impossible, but there's never really a story out of it like, well, how do we know for sure, right? You're still having all these symptoms, but you grew out of it. So how do we know for sure? It's not, well, I got tested, I got evaluated, I just grew out of it, right? Like it's some old pants. So what do you think are some of those common statements people might say?
I grew out of it is my favorite one because I don't understand how you just grew out of something, but that's just me. I'm just out of shape is one.
Yeah.
You're breathing out hard. You just think you're out of shape. Even though you're a $120 soaking wet, you're out of shape. Blaming seasonal allergies is another one. And I only get symptoms when I work out, so it's normal.
Yep. So the two that you said on the front and the back end, right? I'm out of shape or I'm coughing a lot when I start working out. So I must be really out of shape, right? And it only happens when I work out. And people don't realize sometimes you can have what they call exercise-induced asthma, which is basically when you start to do activity, your lungs start to go in overreaction and hyperreaction and overdrive. So we have to be careful not to just assume out of shape is always the answer. Sometimes out of shape is a part of it, but it's not the only answer. And again, you might not ever be able to get in shape, right? I can't really get in shape because I can't exercise because I start coughing when I, go ahead and start trying to work out. Well, maybe we need to treat you for something like an asthma, and the asthma being undiagnosed or uncontrolled or both is going to cause more problems if we don't get in there and do something about it. So with that, I think those are great. I think those are simple things we'll hear people say, and we need to get people to stop saying that and find ways to get into care. So what are the thresholds that we will say a patient may need, PatientZero, to get into a care-seeking situation? Hey, I'm having this. So this is when I probably need to go and get this checked out. Is it, hey, I had one flare one time on one day? Is it I've had it for 10 months? What would you say, patient zero?
So I'm looking at some notes. The note says using a rescue inhaler more than 2 times a week. I would, patient zero would say, if you use a rescue inhaler more than 2 times a month, you probably need to seek evaluation, because I don't have asthma and I don't have a rescue inhaler. So if you need it, then something's wrong. It's just in my opinion. Anyway.
Well, let me jump in and say this. So in those instances, and that's a very specific situation, and I think you're right. What happens with people who have asthma and they've been diagnosed, they may start using their inhaler over and over and not realize that that's a sign that their asthma is poorly controlled. Because they have a rescue inhaler and they use it and it works, they start to think that, in so many words, using it once is good, so using it 4 times must be better. There's a thing called overtreatment, and we don't want to do that. So sometimes the idea of using your inhaler more often is a huge, huge, huge red flag for us that you need to come in and get evaluated so we can stop you from overtreating with one medicine and move it to something else. But that's for people who are already diagnosed, right? Potentially already in care, who need to go back into care. What are the ones that you would say may be there for people who are not in care, or people who may think they need to go in care and they have some of these things that are giving them cause for concern?
Nighttime awakenings due to breathing symptoms, right? That's always scary. That could be asthma, that could be sleep apnea, that could be a couple of things, but that's something that you definitely want to get checked out. Symptoms limiting exercising or daily activity, kind of what we just talked about. I'm not in shape, so I can't breathe. Nah, you might be something wrong. You might not be that far off out of shape. You might be something that you need to get checked out. Or recurrent bronchitis diagnosis, right? Now, to me, that's one that should comment on the level of care that you keep. Because I feel like if you're seeing the same doctor and you have a doctor that's constantly looking at your chart when you see him, then that's something that your doctor should catch. But if you're one of these people that's just going to urgent care to put Band-Aids on things, something that you should take note of. If you've been diagnosed with bronchitis 2, 3, 4, 5 times, then that's something that shouldn't be happening and you need to get seriously checked out.
Absolutely. I think the biggest one that you put out there that people may think, it's not a big deal, is the nighttime awakenings. That's actually, again, another huge red flag for us, not only from a clinical standpoint, but from the idea that it could be an emergency standpoint, right? Clinical meaning, hey, you probably need to get seen, but it could be an emergent standpoint where you need to be seen ASAP, right? So nighttime awakenings due to things with trouble breathing or coughing or wheezing, shortness of breath, that's a huge problem. And that's a huge, hey, let's go ahead and get evaluated, right? Let's not just sweep it under the rug. Some other things that I think are important is, when should we have care that is more urgent than just, hey, I need to go when I get some time. So difficulty speaking in full sentences is a huge one. Visible chest retractions or labored breathing. This tends to happen more in children. When it happens in adults, it's probably really, really bad, but kids tend to have this a lot, where if you think about a kid who's had really, really bad asthma, they start breathing so fast that their chest just doesn't fully expand. It retracts really fast. So at that point, you can't get full expansion. It retracts a lot faster. It causes problems. And then, of course, last but not least, this makes more sense. Of course, I think everybody would agree. If you have trouble where you're not getting relief with your rescue inhaler, when you have that happen, you need to seek care urgently. Doesn't mean you need to go to urgent care, but you need to get somebody to see you sooner rather than later, because these things tend to show that something is about to go really, really, really badly, and we need to do something about it. So with that, patient zero, I think we got a few more things. What is your workup that you would say we need to potentially send folks to have done when they are having potential asthma symptoms like we're talking about? And then last but not least, we'll go ahead and do a couple of stats for patients and some of our listeners. What did you got?
So what I would say is, patients should expect pulmonary function testing, which is also called
PFTs.
And what's the other name for it?
Spirometry. Spirometry.
Thank
So
you.
that's the medical term. See, I'm trying not to hit people with that, but I see
Hey,
you.
man.
You came for me, and I was ready. I was ready.
We're educating the people, and every now and again, patient zero has to quiz the doctor,
Yeah, I see that. I see that.
or patient zero didn't know how to pronounce it, so he made you say it.
There you go.
Either way,
There you go. I think it was the first one. I'm not going to throw you under the bus like that. I think you clearly just wanted to make sure I was on my toes.
it probably was the first one, but either way, it measures airflow obstruction and reversibility, right? So that's something that a patient is going to should expect when going in for asthma or some of these breathing issues, right? Peak flow monitoring, home tracking, you know, a trial improvement confirms diagnosis, right?
Mm-hmm.
Allergy testing, chest x-rays, things of that nature. So those are a few things that patients can expect when having some of these issues.
Perfect. So with that, I think the other thing that people will understand is that common things that most people will hear is a chest x-ray, right? Hey, I know I'm going to get a chest x-ray, which may or may not be pretty basic for the idea of evaluating lung disease. But your two big things that we will send folks for are what we call pulmonary function testing or PFTs. Another thing sometimes people will do is spirometry, which is a part of a PFT. And with that pulmonary function testing, in essence, you sit down at a machine and you're going to do anything from taking big inhales and blowing into the machine, or you're going to basically try to lift certain, I'll say gauges to make it simple, certain gauges up on the machine, right? Sometimes there may be a ball inside the actual tube and you're blowing into the tube to try to hold the ball up for a certain period of time before it falls. And that's basically trying to see what is your pulmonary function. Do you have great function or poor function? Do you have a great lung capacity or a small lung capacity? Do you inhale at a great capacity or not? Do you exhale at a great capacity or not? So those pulmonary function tests are very involved. And if you've ever done one, you will remember it. It's not something that's really small and simple. It's something that is very involved. But the idea of doing it will tell us if your lungs are damaged or not, or if they have function that is not at the optimal rate or level. And if that's the case, we need to then do something when it comes to treatment. So an x-ray is good, but we need to do a little bit more. The trial of the bronchodilator, which is usually an asthma inhaler, that's a good way of doing a very quick and easy test. We give you an inhaler. If you do better, hey, we more than likely think you got asthma. But the true gold standard is to do the pulmonary function test where you go in and have an evaluation. If you do that, that's more likely to tell us how good or how bad your lungs are functioning. With that, takes us to probably the part we should have probably done earlier, patient zero, and I apologize. My notes are clearly out of order. With that, let's talk about stats, which of course is really fun for us because we love math on the show because of what?
Just don't have an opinion.
Absolutely. So what are your stats for people when it comes to asthma? If you have, I'd say just a few stats that you may want to give the folks.
So 25 million Americans are affected with asthma. So I just want to take a pause right quick because that's a lot of people.
Mm-hmm.
25 million Americans are affected with this diagnosis. That's a lot of people. And 50% remain uncontrolled. So that's 12.5 million people who don't have their asthma controlled.
Mm-hmm.
Now, just to put that in perspective, we just told you that these airwaves constrict and sometimes to the point where you can't get any air.
Mm-hmm.
That is a scary thought for 12.5 million people to maybe be walking down the street and all of a sudden can't breathe. That's wild to me. So get in care if you have any of these symptoms. And it's also the leading cause of missed work and missed school days. You know, now granted, I enjoyed missed school days when I was a kid. Still do.
Who didn't? All right. That's what I was going to say.
Yeah, man, because you got to watch Price is Right. You got to watch some ginger ale. You got to drink some ginger ale, man. It was good times.
Was that your go-to? It was Price is Right?
1,000%, man. Price is Right. And Bob Barker with that. And I never understood why he had to have this long microphone. Like he's holding the mic almost to like his belt buckle, and the mic reached all the way to his mouth. And I've never seen a long microphone like that or anything else in my life.
Mm-hmm.
But he had that long mic. I don't know why. But yes, I had to watch The Price is Right when I was sick from school.
There you go. I'm not mad at it. I support The Price is Right for daytime talk shows and game shows while you're homesick. But you better not look like you're having too much fun when you was homesick, because if you had too much fun, what did that usually mean for your parents? What was a statement?
That means you ain't sick and you can go to school anyway.
You go to school anyway. Look, you can't breathe. You can't breathe. You can't breathe.
Yeah.
You better not be having no fun.
I'm walking around smelling like Vicks Vapor Rub, bro. Like my whole chest, my top lip, everything is just straight vapor rub, so I can have some type of open nasal passage, right? Because normally if I was sick, it was something upper respiratory. But then again, I'd balance it out because I'd always watch Jeopardy because I was like still learning, so I didn't have to go to school. I watched Jeopardy. It was fine.
So you learn from Jeopardy more facts and clearly things about life, and you learn finances from The Price is Right because you had to be a better shopper and not overspend. I get it, brother. I'm picking up what you're putting down.
Like nowhere, especially because I'm a 90s kid. Like I grew up in the 90s. There's no way that bar of soap and that box of detergent was $20. There's no way.
None.
No.
Even in California.
It was lower.
Even
in California. Lower. The whole crowd, that's my favorite part. The whole crowd is like, lower. And then they go lower. And then it's higher. And then now you just looking at the crowd side-eye,
Because you listen to
every
the wrong
episode.
folks. That's funny.
And I feel like half the people knew better. But for some reason, it was just, well, I'm going to just listen to the crowd because that's what we're supposed to do.
Well, I'm going to say this part, and the only thing I'm going to say is apparently there is a potential documentary coming out about Bob Barker and some stuff that was going down on The Price is Right. I'm going to just say, you did or you did not?
No, I can see it.
Yeah, and let's just say it wasn't favorable for some of the things that Bob was doing and thinking. So, I'm looking forward to the documentary because I'm a documentaries person, but let's just say...
let's just be glad that Bob hit the upper room before it came out.
Well, that's one way to look at it. I guess so. All right. So we'll come back to the clinical show. And with that, we're going to move on to our second disease state. So we did asthma and we did a good amount of asthma and kind of going through the different parts. And hopefully people learned that asthma is something that is pretty common, but more importantly, it's reversible. It's something that if you get treatment and you do treatment correctly, not ignoring it, not basically skipping over it, you can get it under control and then obviously reverse potentially the things that are going on. So the next thing we're going to go to is...
But if you don't treat it, it's super dangerous.
Yeah, 100%. It is because people have passed away from really bad asthma attacks that they didn't get under control. So even more reason that you should get into care sooner rather than later and not just ignore those symptoms. So we're going to move to the next one, PatientZero, which I'm pretty sure you can imagine what the next one would be because these are phrases that I hear people say, I have it all the time and don't really know what it is, but it sounds good because somebody told them that that's what it is. So what is the next one you would have, if you had to take a guess, what do you think the next one? So we did asthma, what's the next one?
You know what? I'm looking at notes, but had I not had the notes, I would have guessed this anyway because we just talked about it. It's bronchitis.
Bronchitis is probably one of the most common things I hear people say that they have. And being medically trained, I usually can tell they have no idea what they're talking about. So that's always the fun part for me.
My favorite part about bronchitis is that it's not contagious.
Mm-hmm.
So when things are not contagious, it literally makes people feel like it's not a big deal. So I've heard people coughing and like, oh, don't worry about that. It's just a little bronchitis. Not a big deal. It's all right.
Right. Like, it's not like it's going to hurt you, right?
Like it's not going to hurt me.
Yeah.
But it's going to hurt you.
And that's funny
because it's not good.
I was going to say, that's funny because it can be, depending on what causes it. But let's go into it and let's talk a little more about it so people can learn, hopefully. So let's talk about acute bronchitis, if you don't mind. Let's give the people an idea not only of what's happening, but potentially what are some of the symptoms you'll see.
So acute bronchitis is a short-term inflammatory response. So typically it's a viral infection and it causes airway inflammation, right? Not a bacterial infection in most cases.
All right.
Key symptoms.
Stop. And you're going to learn this just like everybody else. Potentially the clinical folks know this and they know where I'm about to go. I'm going to get on my little rant for a second. It is usually a virus. I'm going to say that one more time for the people in the back. It is usually a virus. Why am I saying that? Everybody wants to come into the clinic, and the first thing they say is, can I have an antibiotic? When we give you an antibiotic for a virus, it does two things. It makes you believe that the antibiotic did the work, and then it basically causes the antibiotic not to work well in the future because you're using it at the wrong time. So we're using a treatment that's really not doing anything, and you have this placebo effect in your mind that it was the antibiotic that got you better when it was your good old immune system. So the idea that you constantly have a cough or some type of symptom, and therefore you know it has to be a bacterial infection and you should get an antibiotic, is where you potentially are stepping into that space of kind of doing our job for us. And that's when we get into my favorite, I know my body, I know what it is, and yada, yada, yada. And I'm like, okay, then why did you come here? Because if you knew it, you should have gone ahead and wrote your own antibiotic. That's the problem. If you come to us, we're going to tell you some stuff you may not want to hear, and that, hey, look, it sounds like you're having a cough and nothing but a cough, which patient zero is going to get into a little bit more. It may not necessarily need to be an antibiotic treatment at this point, and we have to give you more time before we can just start giving you antibiotics. Now, some people don't care. They want to get their treatment the way they want, and we had a whole rant on urgent care and how that works. Feel free to go back to those episodes and find it. But I'm telling you that if it's a bronchitis, more than likely, it is a virus, which means we don't need to give you antibiotics. And if we do give you antibiotics, we're not doing anything for you other than making you think that the antibiotic did the work. Continue, patient two.
So question.
Yes.
So since I'm not getting antibiotics, I can get a steroid shot?
Even better, right? Because clearly, with that same episode where we talked about the people in urgent care just handing out these 3 or 4 treatments, antibiotics, steroid shots, and something else like an inhaler or something else like an allergy medicine or steroid pills, it's just overtreating people, and it's ridiculous. So don't do that. Okay, go ahead, patient zero.
When I was a kid, boy, I thought amoxicillin and a Z-Pack could fix anything. Well, like, I'll break my leg and amoxicillin and a Z-Pack could take care of it, because that's just what it was.
It's some Robitussin, right?
Or some Dimetapp.
There you go.
Dimetapp tastes better.
There you go.
But yeah,
that's why I said
so
the idea of treatment is funny when you really and truthfully understand how this works, because you're just giving people medicine. And the people who come in, and go right back to my soapbox for a second, the people who come in and swear that they want an antibiotic and then 5 minutes later, I don't like taking medicine. How is it that you want an antibiotic and you don't like taking, like, you can't have it both ways. And that's what we deal with. I have to sit here and hear people say those words to me and then expect me to keep a straight face when they're asking for something that they just told me they don't want. You just told me you don't like medicine, but now you're telling me you want a medicine. Doesn't make sense. But hey, this is what we deal with. Continue, my friend.
You know, some people like things both ways, man. Like, you know, like some people like to give people props for having the most points in NBA history, but don't want to acknowledge he's also missed the most shots in NBA history or had the most turnovers. So, you know, so these people who like antibiotics and but don't like medicine must be LeBron fans. I don't know. Maybe it's not. Sounds right to me. Anyway,
I knew that was coming. Go ahead. Where are we going with symptoms, my friend?
Key symptoms: choking in the finals, persistent cough lasting 1 to 3+ weeks, mucus production, whether it's clear, yellow, or green. And look, if you got mucus, you got mucus. The color, you can't diagnose yourself by the color. You know, that's...
Say it again. Say it again.
You can't diagnose
Dr.
yourself
Zero.
by the
Dr.
color.
Zero. Say it for the
Dr.
people.
Zero. Boy, I got promoted. Boy, look at me. But you cannot diagnose yourself by the color. Like, oh, doc, I'm healthy. Boy, my mucus is clear. But it's green. It's green. Doc, I don't know. I'm scared. When it's yellow, oh, Lord.
So
admit me.
You do know that this still happens today in 2026 as we are recording this episode. I get pictures of people sending me colors of their mucus and saying it changed from clear to green. So I must have an infection. And what do you think the next thing is?
I need these antibiotics.
Can I get an
steroid shot?
Like, it doesn't work like that. I know you think that your mucus changing color means it now must be an infection. It doesn't work like that, people. Trust me. I wish it did, because that makes my life easier. I wish it was yellow. Therefore, I know it's a virus. So now I don't have to work that hard. I wish it worked like that. It does not. Trust me, if it did, you would get these pills, because now you can literally go feel better and I don't have to do more work. It doesn't work like that, people. So continue. What's the last two symptoms? Because I know we're going long on bronchitis because bronchitis gives us the blues over here. But go ahead.
Yeah. Mild shortness of breath and chest discomfort from coughing.
That's it, pretty much, right? So it's a persistent cough, usually for 1 to 3 weeks. Yes, you can cough that long and don't have pretty much anything else, and you still have a virus. You still need to potentially be patient. I know no one wants to hear that, but that's the way medicine works, and clinical medicine should work. Now, you can definitely go to a place and somebody says you didn't cough for 2 days, you need a steroid shot, a Z-Pack, and anything else, but that's not healthy and that's not helpful. Now, most people don't want to hear that, and that's okay. But if you want someone who's going to treat you and tell you what is true and what you need, then that's what we're doing here. We're not just giving you what you want. We're telling you what you need.
Points. Matter of fact, a question and a point.
Yes.
So are we called patients because we're supposed to be patient? Is that why?
Is this your philosophical moment? Is that what we're doing right now?
I'm just wondering. Are we called patients because we're supposed to be patient? Like, because I've never understood why we would call that.
Good question. I don't know, but we'll have to figure it out and come back to that answer on a future episode. So let's continue.
We will.
I like the philosophy part, though.
And the second part, I clearly did not read up in the notes because now it says color of mucus does not equal bacterial infection.
That's
correct.
So
I just wanted people to know I came up with that on my own because I know better.
Go. There you go. That's what I'm saying. Dr. Zero, you done literally made progress. The astute doctor somewhere has been teaching you the right thing to learn and do, where you're not just running into urgent care and asking these people for a steroid shot and a Z-Pack anymore. So you must be doing well, my friend. So I appreciate it. And antibiotics are not usually needed for bronchitis. Now, there's an exception pretty much to every rule in medicine. And you will say, well, Dr. Jasper, how do you know it's not a bacteria? That's when we get testing done. And that's when we sometimes say, well, let's go into more detail of how long your symptoms have been going on and what's been going on with them so we can then know when to prescribe antibiotics. But if you run into the clinic with color, mucus change, and that I'm coughing, that doesn't automatically tell me you need anything other than treatment of symptoms. So with that, I'll jump in and say you should definitely seek evaluation if you've been coughing for longer than 3 weeks. And if you start having high fevers. High fevers are 101 or higher, 101 degrees Fahrenheit or higher. And if that's persistent, if you have one fever goes away, that could still be a virus and that's it. You don't have to worry about it because your body's fixing itself like it should. Worsening symptoms instead of improving symptoms. Hey, I'm coughing, and it just seems to be getting worse. And then, of course, if you have underlying lung disease, that may cause you to have a worsening bronchitis, right? You already have really bad asthma and you're coughing profusely. Well, we definitely want to consider treating you because it could be something else that is going to progress into something a lot more problematic. So with that, patient zero, how do we diagnose bronchitis if we can? What are the things you might hear us do?
So the things that I'll see, probably you do, is number one, you want to do a chest x-ray. And what that does is you want to rule out pneumonia because obviously pneumonia is terrible and you want to make sure you don't have that. And then you'll do some viral testing, trying to see if flu or COVID, if that's something that's relevant.
Now, this is a thing that it's in the notes, but I know we probably jump past it. It says in bold letters.
Clinical diagnosis.
Usually it's a clinical diagnosis, meaning we don't need a test. We can literally evaluate you, listen to you, talk to you, go through things, and tell you, look, it just sounds like a bronchitis. Now, most of us are not going to just say, oh, we think it's bronchitis and don't do anything. We're going to definitely probably order an x-ray. We're probably going to do some type of testing, maybe pulmonary function testing. And we may also do bacterial testing and viral testing like flu and COVID. But if we're doing all of that and everything keeps coming back negative, and all you have is a really bad cough, mucus or not, we're going to probably say it's a good old bronchitis. And bronchitis means it is going to eventually get rid of itself and you're going to be fine because the only thing you're having is a bad cough. And I have plenty of patience with it. It is one of the most annoying things ever because you just can't stop coughing and people think you're about to basically cough a lung up. But that is pretty much the way that the virus borne illness will potentially cause. So that is acute bronchitis, to not be confused with chronic bronchitis, patient zero, because we just said acute is potentially a short-term inflammatory response, and that's usually 1 to 3 weeks. So what is chronic bronchitis, my friend?
Chronic bronchitis.
Yep. And And this is the thing, I'll say this. Usually by the time that's happening, we referred you to a lung specialist. That's why you're in care, right? We tried a bunch of things on the primary care side. It's not getting better. We don't have a true answer for why you're coughing and coughing and coughing. So we're going to send you to the lung specialist and they're going to do their evaluation and they may do more advanced stuff, more than an x-ray. They may want to do a CT scan. They may want to do some other lung testing where you have different things like sputum cultures, where they're making you cough into, for lack of a better term, a petri dish, which makes it to where they go ahead and see if bacteria or some other fungus will grow. And if that is the case, they treat you for your bacteria or fungal infection. But if they do all of that and they still don't have anything, they're going to do what we tend to tell everybody is treat your symptoms. And that's the biggest thing. So it's just a chronic cough, whether you're bringing stuff up or not. Most of the time you're bringing stuff up, but it's not a bacterial infection and it's not something that we can treat with medicine to just make it go away. We have to give your body time to fix itself. So the key symptoms there is basically, again, a mucus producing cough. It can potentially cause gradual onset of shortness of breath. And people will have what we call the chest colds, right? They keep having issues where they're having those pulmonary symptoms, that chest tightness, that feeling like they're having pressure on their chest. And then, of course, some wheezing and things of that nature. You'll hear people say things like, that's just my smoker's cough, or the symptoms start to get normal over the years. I just cough like this and I've been doing it for years and that's the way it is. Well, again, it's not saying that it is or isn't the way it is. You can potentially still get treatment where we try to lessen the severity of the cough. So patient zero, when should we have people go and get evaluated so we can try to get them in treatment, my friend, for the chronic bronchitis at this point? Because again, acute should start to fix itself in 1 to 3 weeks. So for chronic, when should they start to go in and get care or seek evaluation?
Oh, you want to seek evaluation when you have daily cough with multicolored mucus or any colored mucus. You want to, if you keep having recurrent respiratory infections, and reduce exercise tolerance. So all of a sudden, you hadn't gained any weight, but all of a sudden you're out of breath a lot faster. That might be a problem.
Yep, absolutely. And I think, again, workup is very similar across the board for a lot of the diseases we're talking about. It's getting that pulmonary function testing, plus or minus a chest x-ray or a CT scan. And then from there, if those things tend to be normal, we treat symptoms. If not, then we send you to a specialist more than likely. So that wraps up segment 1, patient zero. I think we did our due diligence on asthma and the different types of bronchitis. And I think we need to give the folks a break. And then we'll come back in segment 2 and finish out with at least one of the other chronic diseases of the lungs. And hopefully folks will enjoy right after this.
I can't believe it. Again, I met a potential client here at the coffee shop, and they ended up going with someone else. Said they wanted to work with someone who looked more established.
Oh no, that's unfortunate, but honestly, why are you still meeting clients at coffee shops? You should check out J. Kenba Executive Suites.
J. Kenba? Never heard of it.
Really? It's a professional office space right here in Baton Rouge. You can rent an office that's already furnished, plus they include Wi-Fi, secure building access, utilities, on-site parking, and they even handle the regular cleaning. All you have to do is show up and focus on your clients.
Wait, they handle the cleaning too? That sounds way easier than trying to make my home office look professional or hunting for a quiet spot at a coffee shop.
Exactly. And if you don't need a full-time office, they even rent out conference rooms for small meetings and workshops. Perfect for impressing clients without the overhead.
That's exactly what I need. Where do I find out more information?
Just visit jkenba.com and schedule a tour. Trust me, you'll wonder why you didn't do this sooner.
J. Kenba Executive Suites. We provide the professional space. You create the success. Visit jkenba.com today.
All right, and we are coming back in for segment 2 of episode 46 of season 5. Patient zero, we talked about asthma and good old bronchitis, your favorite, in segment 1. So that means we're now going to the big guns, and the big guns are those things that people tend to hear about or have heard about and still maybe just don't really wrap their head around what they mean or what they stand for. So we're going to talk about the disease that I think a lot of people may be aware of and just maybe have some reference to it. Hey, I have a relative that may have that. I heard somebody who has it, but don't know what it is. So that first disease is going to be COPD, chronic obstructive pulmonary disease, patient zero. And I'm pretty sure you're an expert on this, but just to show the people how much of your expertise you have, how about you explain to them what is COPD, if you don't mind?
COPD is a cop. Shout out to my brother Jonathan Hill. No, but seriously, it's chronic obstructive pulmonary disease. So what actually happens is you have persistent airflow limitation, and it's not fully reversible. Combination of airflow inflammation, which is bronchitis, and structural lung damage, which is emphysema, right? So similar key symptoms: chronic cough, daily mucus production, progressive shortness of breath, initially with exertion and eventually at rest in the later stages. So, if you sitting up and you have shortness of breath, the first time I ever heard that was during COVID, because that was like a COVID symptom, but also it's a COPD symptom, right? High risk populations of COPD. Us, over 40 now, people over 40, high risk. People with smoking history. Smoking what? Smoking cigarettes, smoking vape pens, tobacco. Okay.
Tobacco and vaping included, because a lot of vape pens have tobacco in it. So yes, it can be that
Perfect.
too.
So my 420 people are straight on this one. So when you have an exposure, especially in the workplace, dust, chemicals, and pollution. Growing up on the Mississippi River, all my plant worker buddies, this is for you. You're at high risk of COPD. And common patient why I can't say this word? I know this word, misinterpretations. Jesus Christ, I can't
That's
talk
right.
today. Misinterpretations. I'll mess up on that.
You
But anyway,
you misinterpreted misinterpretations. That's what that is.
I did, bro. Somewhere my kindergarten teacher is pissed. Because she was a real one. But anyway, common misinterpretations. I'm just getting older. I'm out of shape. And this is normal for smokers. Right? So
let's
any
pause.
chronic cough, go ahead.
Let's pause because you went through quite a few of them. So let's back up a little bit for folks. So let's go all the way back to the beginning, because I didn't want to step on your toes, because I know you were rattling off all this expertise you have. But COPD, the biggest thing that people may not realize is that COPD is basically, in my opinion and how I explain it to a lot of patients, is just an extreme case of asthma that you can't stop. Once your asthma is out of control, or there's enough damage to the lungs and the volume of the lungs and the function of the lungs, it's not reversible. So once you get COPD, it's trying to stop it from progressing, but you can't undo it. Similar to when we did the episode on kidney disease, patient zero, once you have damage to your kidneys, you can't get the function back. It's just stopping it from getting worse and trying to hold on to that function as long as possible. The lungs are very similar in this capacity. So if you get damage on a COPD level, you have now caused enough damage that we are now saying, look, we can't reverse this. There is no treatment that's going to make your lungs go back to the way they were. We just have to maintain and hope that they don't get worse. So that's why we're trying to keep you from getting to a COPD when we say get into care for asthma, and potentially get you treated for things like bronchitis, to where you may not be able to stop the bronchitis from being present, but you can help control the symptoms. And if we can do that, and we eliminate all of the things that are hopefully going to cause damage, we won't have severe COPD that will do what patient zero just talked about, where you're now having these symptoms even when you're at rest. You're now extremely winded sitting still. You're having these crazy bouts of coughing and bringing up all this mucus, and you have no idea why. And I've had patients and family members that have had COPD, and it is very tough to see because they are now taking multiple treatments, but it's not stopping anything. It's just trying to keep them from getting worse. So we don't want that to happen. And the biggest thing, patient zero, to always take home, if you are a smoker, usually of tobacco-related products and things that are potentially in those things like cigarettes or pipes or vapes and things of that nature, you're going to be in essence, public enemy number one for this disease process. It's going to come for you because those people tend to cause a lot of damage to the lungs over time. Now, that doesn't mean if you're, having a small smoking history. This is when you smoke chronically, right? You're talking about decades, 2-3 decades in smoking tobacco-related products for that long. You're going to have damage to the lungs that end up becoming chronic, and the chronic disease will potentially cause obstruction. So now you have chronic obstructive pulmonary disease because you can't get things out once they get in because of obstruction. And because of that obstruction, we're now having trouble with breathing, coughing, wheezing, and so on and so forth. With that, patient zero, what are the things we would tell people that they need to potentially hear or feel or see that would make them go and get evaluation? So what are some of those things? You were about to get into it, but I wanted to go back and give some of my clinical guidance, if you will.
Yeah, sure. It wouldn't be a medical show without it. You have to do that. But yeah, so you need to seek evaluation with any chronic cough plus smoking history, right? So me personally, I think any chronic cough period, you should get that checked out. But especially knowing, because of everything you just said about tobacco users, if you know you have a smoking history and you have a chronic cough, get checked out. Shortness of breath with routine activities. Let's say, getting groceries out the car, you're walking back in the house, all of a sudden you're out of breath. That's you need to get checked out. Decreased exercise tolerance. That's something we talked about earlier.
Mm-hmm.
You keep doing the same routine, but all of a sudden you're out of breath faster. That's a problem. And frequent respiratory infections. That's another repeat one.
Absolutely.
If every other week you got a respiratory infection, something bigger is wrong than just having a respiratory infection.
Yes,
Get
sir.
checked out.
Yes, sir. So those are really good rules of thumb to go and basically use when it comes to, hey, I may need to get checked out and I may have something that is chronic in nature. So if the symptoms are suddenly worsening, like shortness of breath, you're going from having a little bit of sputum to where now you're making a lot more sputum, or mucus, which is another word that we will hear people say. That is all things where we say, okay, we may want to have you come in a little bit sooner than let's wait and get seen when we can get seen, right? You may want to be seen urgently when you're having worsening shortness of breath, increased sputum production, increased mucus production, and it's just getting worse and getting more noticeable by the moment. With that, I think the ultimate thing that we would say patient zero, and I've kind of said it over and over again, what is the workup that you think we're going to tell people they need to have to get evaluated for a chronic obstructive pulmonary disease or a COPD? What is the gold standard? Spirometry, correct. So a spirometer is basically something that you will have people use when they are in the hospital to try to open their lungs and make sure that they are getting lung exercise so they don't get a pneumonia when they're in the hospital and they're hospitalized.
I got one of those.
A lot of people do, and they don't use them because they have no idea what they do. And more importantly, they don't think they're helpful. But if you realize that people who use them don't get pneumonia and other lung diseases because they're working their lungs out using this device, you can use it more often. But that is basically
Patient
the
zero.
idea. Patient zero, there you go. That is basically why we potentially help people go in and get evaluated sooner than later, because we want to stop you from having progression of the disease to where we can't undo the damage. So we definitely would do that. And then other things are your chest x-ray, your CT scans. And then in some really, really severe cases, we do something called ABGs, or arterial blood gases. And those ABGs can be very helpful to see how much oxygen is in the blood and if it's doing what it should do. If all those things come back and they're abnormal, then we know we got a problem and we know we need to treat. Patient zero, let's go into some stats since we didn't do that on the front end. And again, I apologize. My notes are a little backwards. I got to do better. This is why people come here for patient zero and not for Dr. Jasper. But what are some of the stats that we have for COPD, if you don't mind giving it to the
1 million people diagnosed in the United States, right? That's a lot of people. Up to 50% undiagnosed. So if you got 16 people that's already diagnosed, there's another 8 million that probably haven't been diagnosed. So imagine having these type of symptoms and not getting checked out to get diagnosed. Take care of yourself, people. And it's the third leading cause of death worldwide. Third.
Yeah. And again, We'll have to definitely fact check, and I'm going to try to do that to make sure, because again, my notes may be a little bit off. It could be the third. I'm not going to say it's not. It might be something else. However, the fact that you have 16 million people in the United States that probably are working and having symptoms, but maybe not being in treatment, or if they are in treatment, they're still not getting the right treatment. That's a huge thing. And then again, you have 50%, 8 million, as you already said, that just basically deal with it, right? Like, I'm just going to walk around and cough and get more fatigued and have more shortness of breath. And over time, believe it or not, with bad COPD, you start to lose weight because you're coughing and breathing so rapidly that your body starts to basically feel like it's in exercise mode all the time. So now you're starting to lose weight and you think, oh, I'm getting healthier. No, you're getting sicker. So we need to do better and make sure people get into care. So we don't have a third leading cause in the third leading cause worldwide of death, because we just have 6, 7, 8 million people who are not in care. So that makes absolutely no sense. So with that, we're going to slowly but surely close out. With that closing out period, what I'd like to do, PatientZero, is briefly talk about emphysema, the other disease that a lot of people hear about, but may not understand what it is. People tend to think they're one. COPD is one thing and emphysema is something different. They're actually very similar. And I would like people to at least get a sense of what the difference is. So you talked about it earlier. You definitely said it when you were giving your intro on COPD, but let's go in a little bit on emphysema. We're not going to spend a ton of time because it could take a little bit more going down the rabbit hole, and we don't want to get too long on this episode. But let's give folks a little bit of emphysema, if you don't mind.
So emphysema is something within COPD. Essentially, is structural lung damage within the COPD, right?
Mm-hmm.
So it's destruction of the alveoli, which is your air sacs, and it reduces your surface area for oxygen exchange. So it's making your lungs essentially harder to breathe. It's
Okay.
making them work harder.
So let me say this. It is alveoli. Alveoli. You were close. You went
Sounds
ravioli.
like pasta.
You went ravioli. I could tell. So
Sounds like pasta.
obviously we're recording when you're hungry. Nothing wrong with that. I'm not mad at it. And this is what happens when we record at dinner time. So I apologize. Next time I owe you a happy hour meal for the alveoli that we didn't eat. So
You know, I need them steak frites and the gorgonzola butter.
there you go. There you go. So based off of that,
Smoked old fashioned.
I'll support you on that one. But the alveoli are the basically pockets that are at the end of the tubes in the lungs. And again, we may have to put a picture up for the folks, PatientZero, of what alveoli look like. But the idea of that is where those pockets at the very end of the tubes in the lungs sit, they are now damaged. So now imagine a door that doesn't open so things can go through it. And now you're trying to get oxygen to walk through a door that isn't opening. That oxygen now is basically stuck and it's not getting into the blood. So it's going to cause more damage over time where you're not getting enough blood flow with oxygen in it to now go to other organs. So now organs are going to have more problems, like your kidneys, like your brain, like your heart, because your lungs aren't working the way they should. And that's why emphysema is so bad, because not only are you having trouble with the breathing part, COPD, but you're now having damage to the structure to where it doesn't function right. So you got two insults to a potential patient, which is now going to cause more problems. And that's the huge issue that we run into. So yes, you can have COPD and emphysema. More than likely, it's one and the same. If a person tells me they have emphysema, I pretty much know it's COPD related, but it tells me that there is severe damage. And I do have a patient currently who has emphysema. He is very, 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 very thin, and he has been a smoker for well over 40 years. He is the prototypical textbook person that has an emphysema diagnosis. If you saw the gentleman, one of the nicest people you ever meet, one of my favorite people to come into the office, love talking to him. But he truly and truthfully fits the description that we just talked about. So he is one of those people that had symptoms and didn't know he had emphysema. And as I'm talking to him, I'm asking him some of these. He's like, oh yeah, I do have that. Oh yeah, I do have that. And eventually we did all of the stuff we talked about. We got him imaged. We sent him for a CT scan. We did screenings for lung cancer because he's a chronic smoker. And basically the CT scan came back and said he has emphysema. And I told him, I said, I don't know if you know this, but you have this diagnosis. And he was like, well, that's probably why I have so much trouble breathing. And I was like, yeah, that's probably why you've been having it. And it's been such a long going thing. And more importantly, my last thing was, That's probably why you have such a hard time getting weight on you and maintaining your weight, because he kept saying, I eat a lot and I just don't gain a lot of weight. It's because his lungs are working so hard that he is basically having trouble oxygenating his blood, and it's going to keep making him work harder to breathe. So now he's going to burn off more things that he's eating. And it's just a really bad situation because it's going to make it to where it's hard down the road. So this is living proof that this exists. And we probably know people like this, Patient Zero.
Question. You said he's the perfect description, right?
Mm-hmm.
Does he wear the T-shirt with the little pocket on the front with the slim Wrangler jeans?
I don't know about the jeans, but he definitely has T-shirts with pocket on the front, and you know what's in the pocket.
Yeah. Box of cigarettes.
Cigarettes, exactly. And he comes. Now, he does better now. He knows not to come in the clinic with it because he know I'm going to throw them away. That's just how I roll. So I'll take your cigarettes and throw them in the trash when you come into the office because I'm telling you not to smoke and you're not going to come in and do that. So he now leaves them in the car at least, but I definitely can tell when he's come in and he had cigarettes on the way. Now, to his credit, he's doing way better. He's down to 3 cigarettes a day from a quarter of a pack. No, I'm sorry, 3/4 of a pack. And if you know anything about cigarettes, 3/4 of a pack is about 15 cigarettes a day. So going from 15 to 3 is a huge achievement, and we're working to get him to stop. So I'm confident that he's going to stop. Got a lot of work to go, but hey, we're going to do it, Patient Zero. So last but not least, my friend, anything that you would tell folks about emphysema in terms of statistics, disease process, anything you want to share with folks? Because we already know some of the things, right? It's a chronic issue. We also know that it's going to cause damage to the lungs. Is there anything else you want to tell the folks that we haven't gone over that you may say, hey, from the notes, I'm looking at this and I realize this is something I probably would like people to know?
Absolutely. The indicators when to seek evaluations are almost the same. So that's not something we need to go through. It's just some of the key facts is strongly linked to smoking. So I'm not saying that you shouldn't smoke cigarettes, but if you are smoking cigarettes,
I am.
all right. Well, I was just trying not to be judgy because I think cigarettes kind of gross, just my personal opinion. But if you like it, I love it. But if you know you're smoking,
which is, hold on. Let's not, you already said the phrase. We got to explain it for some folks that aren't in the same demographic as us. When you say, if you like it, I love it, what is that really saying?
Hey, that's on you. Like, I'm not with it, but do you.
Right, exactly.
That's what that means.
It is a black person's way of trying to compliment and insult you at the same time. Or I'm saying that wrong. It's a black person's way of insulting you without insulting you to your face, if that helps. Just to give some folks some clarity.
It's not insulting. It's just saying like, hey, I'm not with it, but I'm not judging. Like, I'm not doing it. If you like it, I love it. Hey, bro, it wouldn't be me, but hey, that's your life. You do you.
All right, so we're going to have to do on social media this one too. We are going to have to literally clip this and say, what is if you like it, I love it really mean? Patient Zero is saying that it's not an insult, whether it's a light insult or not. It's more of you do you, I'm not with it. I'm 100% thinking that we're basically telling you, stop doing that dumb stuff. But we don't want to say that, so we're going to say it in a nice way. So I think it's more of a nice insult, if that can be a thing. It's an oxymoron, I'm sure. Patient Zero says it's not. So we're going to have to figure this out because I'm pretty sure.
It's definitely not.
The congregation is going to decide with me, Patient Zero. I'm saying it out loud.
There's no way.
All right.
No way.
Okay.
If you went out and bought a Benz tomorrow, which I know you're not, but let's say you went out and bought a Benz, and I'd be like, man, you bought a Benz? That's a nice car. But, you know,
and I'm going to say,
$300-$400 oil changes.
I'm going to say,
if you like it, I love it. I love it. And then I'm going to go get my Chevy and then go buy my business. You know what I'm saying? Like, I don't think a Benz is a bad thing. I'm just not paying $300, $400 for oil change. That's just me.
I mean, when you have it like that, that's probably not a big deal, but I get it. But again, if you like it.
Bro, there's some things that no matter how rich I am, I'm not doing. Like, I can't buy a $70 t-shirt no matter how rich I am. T-shirt shouldn't be $70. That's just me. But anyway, back to emphysema before we go off the deep end.
Too late.
What I was saying was, if you know that you're a smoker, you should take extra precautions to understand that something is more than likely to be going on with your lungs than the next man. You should be aware of this. So you should be getting yourself checked out more often. So yes, emphysema is strongly linked to smoking, damage is irreversible. I repeat, it's irreversible. And it's a major cause of long-term oxygen dependence. So you see these people walking around with these oxygen tanks. I see them in Walmart. That doesn't seem to be the most convenient thing to have to kind of pull around and roll around with you. You know, you don't want to be that person because it's not convenient. You don't want to be dependent on oxygen. You might want to think about that. This is a real thing. And emphysema affects 16 million Americans. That's a lot of people. If you're smoking, just be aware of it. And that's all I got to say on emphysema.
Yeah. So with that, I think we did the people a service of talking about lung diseases. Now, there are way more that we could go into. And, you know, as time goes on, we may do a little bit more. But I think we're kind of checking different parts of the body off. So again, we did diabetes. We did high blood pressure. We did the kidneys. We did the thyroid. We did cholesterol. We did mental health. Now we've done some lung stuff. So I think we only have a few more that we're going to do, Patient Zero. And I think from there, we are doing a good job of doing the people the service of giving them access to some of this medical knowledge that they may otherwise go without. So kudos to you, my friend, and kudos to myself for basically giving you the platform to be Patient Zero, because that's what the people come here for. Again, I'm just here carrying the luggage, and I'm okay with that. With that being said, my friend, let's close out. Anything that you want to touch on about today's episode in life. As we have already determined, Patient Zero has said he would give us a rant. Doesn't have to be a long one. Now that we've determined folks come here for him, he's supposed to give us a rant. Now, if you're not ready for the rant today, we can do it next episode because you're now on rant notice. But anything you want to do to close out our episode, my friend?
You know what? We kind of touched on it briefly. Shirts with pockets on it. Can we stop it? Like really? Like the T-shirt with the pocket, or my absolute favorite, sarcastic favorite, the dress shirt with the pocket. Like I'm getting ready, I'm about to put on a suit, I'm trying to get fresh, and all of a sudden I got a pocket on this dress shirt. Like what am I gonna put in there? I'm going to dinner. Is it putting a calculator in there, putting an ink pen in there? Like why are we still wearing shirts with pockets? Like we live in a digital age. You don't need to put a pen in there. I just don't understand shirts with pockets. It bothers me. Like when I see a shirt with a pocket, I won't buy it. And when I see somebody else wearing a shirt with a pocket, it irritates me so much to where, like, what do you put in this pocket? So my brief rant for the day, and I'm pleading with all our listeners, for the love of everything that is holy, stop buying shirts with pockets, unless it's like a fashionable pocket. You know what I mean? Like you buy a shirt with the two flaps on it because, you want something on the shirt, then that's a little different. You know what I mean? Stuff like that, or like a jean jacket with those pockets, that's cool. But like just a regular Oxford shirt or a T-shirt, or God forbid, a polo shirt with a pocket, like why are we doing this? So like I plead with you, stop it.
And that is your closing thought, I'm assuming. So we will go to Dr. Jasper, who is not ranting. I already think I did my soapbox for the moment. I'll close out with the idea of getting in care is important. And it's not just important to get in care and not engage in care. You want to be in care. You want to be accountable. And more importantly, you want to make sure that you're doing what the doctor and you have come up with and executing the plan. I used this analogy earlier today with one of the patients. I said, I am literally in the game with you, but I'm calling the plays and hoping that you can execute the plays once you leave the office. Here's the playbook. You have to execute the plays. I can't do it for you. I can't literally give you the prescription and then make you take it. I can't ask you to go get evaluated for lung disorders and lung disease, and then you don't want to go. You have to be on a team with people, and you have to be ready to execute, and being in care consistently, and also being in care with someone who's going to really work with you is really important. So please, please, please do that. If you're not doing that, then you're doing not only yourself a disservice, but probably the people around you who like you, love you, and care for you a disservice. So let's do that, and let's do that soon. And more importantly, Patient Zero, where can the people find you for next episode, or in between next episode and today's episode?
You can find me at Becknell Media on Instagram, George_Becknell on Twitter, George Becknell II on LinkedIn. And you cannot find me at the shirt with pockets though. I won't be there.
You're not going at all, I'm assuming. I got you.
Won't be
Well,
there. Shirt with a pocket, I don't want it.
you're going to be outside picketing. I get it. So with that, you can find us at Byja Clinic on our website, www.byja.org. You can find our nonprofit organization that we have founded to give charitable care to those who can't afford the direct primary care membership, and that is the Byja Charitable Alliance. The website there is www.byjaca.org. If you have not done so and you listened this far, number one, thank you. We appreciate you for rocking with us. Please like, subscribe, and share. The two things that we need most is more subscriptions and more sharing. So please do that. And of course, if you want to share some love, give us some feedback, give us some comments, let's do that as well. Last but not least, on social media, you can find a clinic at Byja Clinic for Instagram, LinkedIn, and Facebook. And then more importantly, if you have not done so, go on YouTube and check us out. We're pretty handsome brothers, in my opinion. PatientZero, I think that's pretty reasonable to say. So the more that we can get folks to realize that we are taking this seriously and we're trying to educate the masses, the more that we're going to make change and make sure people are living longer, healthier, happier lives. With that, thank you for listening to Byja Radio, and we will see you next time.